So good evening, everybody. We are here again from Eastern India Journal Ophthalmological Congress. I am Dr. Swaraj Bhattacharjee, Honorary General Secretary of EIZOC, welcoming you all. Today we are having our Ophthalmology Resident Teaching Series 28. And today our topic is Thyroid Eye Disease, Evaluation and Management. We had with us our mentor, Dr. Ajit Babu Majid sir, the Chief Coordinator, Dr. BNR Subhuti sir, and our CSC, Dr. Sabyasachi Patnaik, along with our President, Dr. Pranav Ranjan sir. Today the session will be moderated by none other than Dr. Madhusmita Behera, and our speaker is Dr. Savari Desai from PDG Hinduja Hospital, Mumbai. We had our panelists in the list: Dr. Sahil Agarwal, Dr. Devi Kant, Dr. Apurva Mittal, Dr. Mihir Mishra, Dr. Jaita Das, and Randhir Jha. And we had discussions from different PGs, from different medical colleges and around. This is a very important webinar where important topics are being covered. The mastermind of Dr. BNR Subhuti sir. With this, I welcome everybody and request our president to give the welcome address. Over to President sir, Dr. Pranav Ranjan sir.
Thank you, Dr. Swaraj Bhattacharjee. And this has been a regular feature, the Ophthalmology Resident Teaching Series. The number itself speaks. This is the series number 28, and it has been a regular affair, scientific deliberation we are having. The topic is very common and very important, thyroid eye disease, and the speaker is Dr. Savari Desai. The webinar will be moderated by Madhusmita Behera, and we have an expert panel in Dr. Sahil Agarwal, Dr. Devi Kant, Dr. Apurva Mittal, Dr. Mihir Mishra, Dr. Joita Das, and Dr. Randhir Jha. Our gratitude to the mentor of this webinar, Dr. Ajit Babu Manji, Dr. BNR Subhuti, the Chief Coordinator of this program, who has burnt midnight oil for the last so many months and years together. My gratitude also to the ever dynamic Secretary, Dr. Swaraj Bhattacharjee, and the Chairman Scientific Committee of EIZOC, Dr. Sabyasachi Patnaik. With these words, I welcome all the residents from the East and beyond to have a fruitful discussion, and you can ask all your queries, put forward all the questions to the speaker and to the panelists and to all of us. Ajit Babu Manji is always there, BNR Subhuti is always there to come up with the answers. And an announcement from the EIZOC platform that we are going to have the annual conference in Kalimpong on the 29th, 30th November and 1st of December. The registration will start from Independence Day, that is 15th of August, and all of you are invited to attend the annual conference. With these words, over to you, Dr. BNR Subhuti, sir.
Thank you, sir.
Dr. Sabyasachi Patnaik is there, the Chairman Scientific Committee, for his few words of wisdom. I think Dr. Swaraj, I think he's not there.
Yeah, he is not there.
Okay, sir.
Over to
Dr. BNR Subhuti, sir.
Yes.
Thank you, Dr. Pranabji and Dr. Swaraj Bhai. Once again, I welcome you all to this ORTS webinar. Am I audible?
Yeah, you are audible, sir.
Yeah. Visible too. Yes, we, as has been told by our president, that we conduct this program the last few years since the days of Corona, and we select good topics and good speakers for the post students, and we see that the post students are really very much motivated to join this program. And today's speaker, none other than Dr. Savari Desai, and topic is thyroid eye disease evaluation management. As you know, thyroid is very common, and thyroid eye disease is very common. In our country, more than 42 million people are suffering from thyroid disease, and out of which about 150 plus per 1 lakh population has thyroid eye disease. You see how common this eye disease. In every clinic, every OPD, you see a lot of thyroid patients. So today's topic is really very interesting topic. and well known by all of us. So we'll discussing this topic with our panelists and the moderators. So this is the EIZOC team always supporting our program, and our Dr. Ajit Babu Majid, the mentor. I welcome you all to for this program, where he selects very good interesting topics and the speakers. And yes, today's speaker is none other than very young and dynamic Dr. Savri Desai, and she will be introduced by our moderator today, Dr. Madhusmita Behera. So Madhusmita Behera is the senior consultant, cataract, orbit, and octoplasty at Rotary, Techno Nethralaya and HP Ghosh, Salt Lake, Kolkata. And these are our panelists, Dr. Sahil Agrawal, he is the assistant professor at the RP Center, AIMS, New Delhi. Dr. Devi Kant, associate professor, AIMS, Patna. Dr. Apurva Mittal, consultant, orbit and octoplasty at Thind Eye Hospital, Jalandhar. Dr. Mihir Misra is regular with us in all our programs. He is a consultant, MGM Eye Hospital, Raipur. And Dr. Jaita Das, senior consultant, Disha Eye Hospital, Kolkata. Dr. Randir Jha is again very common panelist in all our programs. He is from Bihar. And today's discussions, yes, there are about more than 10 posted students today. And Dr. Sasmita Panda from MKC Medical College, Barampur, and Dr. Rupali Misra from MKC Medical College, Barampur, Odisha, and Dr. Christopriya J. Kaimal from Silchar Medical College Hospital, Dr. Renuka J. AIMS Patna, Dr. Smruti Misra from Burla, Mimsar Burla, Dr. Sada Satapada, JP Rotary Cuttack, Dr. Sanya Parak from AIMS Raipur, Dr. Subhajit Bagchi, RIO Kolkata, Dr. Elisa Nanda, and Dr. Nahik Jawad from RIO Cuttack. So these are the discussions. So I think I already ventilated our thoughts to our speaker today to interact with these students every slides. So now I welcome all of you to this program and all the viewers also behind the screen to this program. Now it's over to Dr. Ajit Babu to say a few words before passing on to Dr. Madhusmita Behera.
Yeah, thank you, BNR. Actually, this topic is very, very essential topic because it is across all the specialties. Thyroid eye disease is very common, and we need to deal with it very much. And I am very confident that Savri will do justice to this topic, and I request her to make the residents interact so that they will get the best benefit out of your talk. Thank you very much.
Thank you, sir.
So over to Dr. Madhusmita now. Dr.
Madhusmita.
Madhusmita,
Good evening,
moderator.
sir. Good evening, everyone. Dr. Savri Desai, she is a renowned orbit and oculoplasty surgeon. She is currently working at Hinduja Hospital, Mumbai, solely practicing ophthalmic plastic, orbit and ocular oncology. She was an honorary consultant at TMH, Mumbai, and has helped establish some of the ocular oncology protocol. She has been a gold medalist in her PG. She was the organizing secretary of the Midterm Oculoplasty Conference in 2018 in Mumbai. Scientific organizer for the annual Oculoplasty Conference, November 2022, Mumbai. She was the editor for the official newsletter of the Oculoplasty Association of India called EIZOC for 2 years. She is currently the treasurer of Oculoplastic Association of India since 2021. She loves teaching and presenting her work through scientific papers, publications, and surgical videos. She has won many international and national awards. Some of them are Best Show Video Award in 2006 at American Academy of Ophthalmology, Best Video APAO 2009, Asia Pacific Society of Ophthalmology, Best Paper Orbit and Oculoplasty at APAO in 2013, Gangadhar Sundar Medal for a Young Oculoplastic Surgeon at OPI 2013, Best Paper Trauma on using a flexible silicone block for the repair of floor fracture and enophthalmos in AIOS in 2015 conference. Best overall scientific paper in Maharashtra State Conference for the work on contracted socket in 2017. Today, ma'am will talk about thyroid eye disease, evaluation and management. Welcome, ma'am. Over to you, ma'am.
Thank you so much, everybody. That was quite an introduction. I just first share my screen before we start, so that. Okay. Is the screen visible?
Yes, ma'am.
Yeah.
Okay.
Make it. Make
Yes.
it.
Yes. So
Share.
first and foremost,
Good.
I'd like to thank the entire EIZOC committee, Dr. Subudhi, Dr. Ranjan, Dr. Swaraj, who's not here, Dr. Patnaik. Thank you for that very generous introduction, Madhusmita. Thank you so much. Dr. Ajit Babu is a mentor for maybe EIZOC, but he's pretty much been a mentor for all of us, even at LV Prasad. So since we all usually attend a common class, there was much to learn from him. I think the thing I remember most about him was that he was approachable to most of us students. I mean, everybody knows about how scary fellowship is in LV Prasad, but he was very approachable. He joked around, but he also expected you to get the work done. And he was very particular about how you wrote your findings and everything. So there was a little bit of crossover sometimes for oculoplasty and retina. And these are the things I remember. And luckily, we've been in touch, and when he told me, Sabri, there's a thing there's no question of saying no. So thank you so much, Dr. Ajit Babu, for even considering me for this.
Thank you for accepting.
On the group of panelists, there are a lot of young friends and colleagues who, already practicing amazing oculoplasty work. Joita, Sahil. So I'm really happy and little nervous, so that I don't get grilled, hopefully. On that note, let me start. So, thyroid eye disease is a really vast topic. So, just put up the slide. I always tell so we have a bunch of residents also, and we have classes. So, we have, these are the names that keep popping up, and often it's assumed that Graves' disease is only associated with hyperthyroidism, which is true. But like I tell them, you can be a Vijay, you can be, many names, but finally you have to just bring it down to the patients and call it thyroid related eye disease or thyroid eye disease. With the thyroid eye, with the, TED talks becoming very common, patients often remember that TED or thyroid eye disease is a common name to know when you're explaining to your parents. So, patients. So, we see different presentations in our clinic, and these are some of the mildest to the severest ones. Now, is it possible that all are thyroid eye disease just because I am presenting it and showing these photos? Well, there is a yes and there is a no. So, let's take it one step at a time. So, I like to break it down with my residents very simply. There are a couple of questions we are going to ask and do it like an algorithm so that you remember it, which in turn, not only for your clinical evaluation, but also for your writing notes. If you ever blank out, this is the way I feel this is the best way to go besides just, learning it up and, seeing it. We see in our clinics, though, on a daily OPD basis, we see quite a lot of thyroid patients. Also, because now there's a referral pool of endocrinologists in Mumbai and Maharashtra, Gujarat, Rajasthan, who send it to me at Hinduja and my clinic. So, second is, do I need to treat it? And the third is, how do I manage it? 3 points. That's it. This is the 3 things you have to remember. So, we'll go to point 1. Does the patient have thyroid eye disease? So, the first thing when the patient comes is you're looking at the patient, okay? And there are multiple things you're seeing. So you see sometimes something called as eyelid retraction, which occurs in 98% of patients presenting it and is the commonest and the first sign that you may see, which presents to them as one eye either appearing smaller or bigger. Then you see periocular soft tissue swelling, proptosis, and sometimes even extraocular muscle restriction. A common misconception, even among residents, is that, oh, it's thyroid, then why is it uncommon? And as you can see in a lot of these photos, especially in this gentleman here, he has predominantly a unilateral thyroid eye disease, maybe some conjunctival signs, but honestly, nothing else. So it is considered asymmetry is not uncommon. It is common. So if you are suspicious and this is what the patient is presenting to you in the OPD, then you go on to the next thing. History. what am I going to ask the patient to do, and what imaging do I require? So let's see, what do you ask in history? History, of course, you want to go through simple things of ptosis and proptosis, which is the eye which appears smaller, which is the eye that appears bigger. So, like I tell my residents, the ptosis and the proptosis sometimes overlap in terms of ipsilateral eye appearing smaller. There can be many causes, such as enophthalmos, other condition which cause an enophthalmos. And there are conditions which cause proptosis, such as myopia, glaucoma, blow-in fractures. So this is similar where you're asking first, when did you first notice this and which eye do you think? Now, why is it important in thyroid eye disease to ask this question? This question because a lot of times patients themselves know or pointed by a relative, or often now as we see in selfies and photographs, they pick it up, is considered the point of when a thyroid eye disease may have started. And that's very important to remember. So here is two examples of 2 decades. A young boy in his 20s who insisted that he had bulging in both the eyes, which was relatively recent, and had come for a medical clearance to be a pilot and was told that he had thyroid eye disease. Let's come to the investigations part later. And another lady who said that her right eye was bulging, there was edema, and she was finding a little bit of blurring of vision. On taking history and digging further, we took out some of his old photographs. Now, something like this, you might think he's a myope, but he was not. And we further asked him to show old photographs. Now, if you look at a chronology of photographs, this patient, even in his between 15 and 18, has already significant lower eyelid retraction. Also, in his younger age, he had a little bit of upper lid retraction. Could this patient have had thyroid? Yes, maybe. But there is no investigation which is done repeatedly for him by many ophthalmologists, endocrinologists, and physicians that's suggestive of anything. So, photographs help. In this case, this patient did not have, could have been a condition called euthyroid, but he didn't. But his eyelid retraction had not changed from his mid teens to in his 20s. So, this is something you want to look at. Coming to this lady, if you look at her, this was a photograph, was almost about 5 years old. Absolutely, there has been a worsening, but as you can see, there is an asymmetry. So she's a known case of thyroid with a family history in her mother of thyroid, but this never bothered her. What bothered her now was one of the common eyelid signs we see, which is the lifting up of the eyelid in the lateral portion, classically called lateral flare, and the proptosis increasing along with fat bags and edema, which has occurred over the last 5 years. And this kind of fat bags is a classical appearance we see in thyroid eye disease. So history is important. Chronology is even more important. And often we ask for photographic documentation. Along with this, we then go to investigations. So, of course, you have to do your usual vision, refraction, pupillary investigation. Color vision is very important. And, of course, your fundus examination. But we are not going into the details of those, and we're going to focus on the thyroid. So, coming to investigations, there is the blood investigations and radiological investigations. So, usually I used to prescribe T3, T4, TSH. But often my endocrinologists, some of them started doing free T3, free T4, and some of them started doing then TSH. So I try to understand. So there will be a range of endocrinologists who want FT3, FT4, and some want without it. So for the purpose of ease, I usually just do T3, T4, and TSH. Now I know which endocrinologists who have referred to me have a tendency to do what. So accordingly. But this is a simple profile. The reason I put this is often I found even ophthalmologists only doing a TSH. But that is not enough. And we'll come to why. Why you have to do T3, T4, and TSH. And there's another thing called TRAB. So, thyroid receptor antibodies, while without going into detail, this is just to explain the concepts. Because often when we give something called TRAB, which we'll come to in the next slide, people will call you up and say, but can I do a TSI or this clinic or this pathology center's office? So, basically, there are two components very similarly put. They both pick up and are sensitive markers to know if thyroid eye disease is existing, because these are sensitive markers for thyroid eye disease. So, as I've understood over the years from my colleagues, endocrinology, have explained this to me, this is a summary of this. So, in some places, they call them thyroid receptor antibodies, in some places, they call them TSIs. So, this is still what we need to do. So, you can even write backslash, backslash, but TRAB is one of the commonest. So, what are thyroid receptor antibodies? Basically, they're sensitive markers where a TSH, T3, T4, TSH may be normal, but these may be abnormal. And they're usually above, say, about 1.86 or 2 in a lot of patients. And this is a good indicator to know some of these. That yes, you may have hyperthyroid, to monitor antithyroid drugs, and something called as euthyroid cases, which means that the patient is presenting with classical eye signs, may have, even have an important family history, but patients T3, T4, TSH over time continuously people have done and comes negative. But if clinically they are there and this comes positive, then you are looking at a euthyroid patient. What is a euthyroid patient? We mostly know 70 to 80% are clinical hyperthyroid, which is classically known as Graves' disease. But there is 10 to 15% of hyperthyroid who also present with thyroid eye disease signs. But this is the component that we have seen on the rise over the last decade. That is clinical euthyroid, younger patients coming, with classical thyroid eye signs being batted around because they're not fitting T3, T4, TSH abnormal values. And often some people may or may not do TRAP. And a lot of times in these patients also TRAB may be negative. So we still need to consider that these patients need to be treated. These will progress like thyroid eye disease. Okay. However, they tend to have lesser aggressive and severe signs of thyroid eye disease. Now, we'll leave euthyroid aside because we'll come to clinical cases later. Let's go to, this was your blood investigation specific to thyroid. Let's go to radiological. Is there any questions that anyone wants to ask so far, or I'll just finish the radiological and then we'll move on? So this is the first question we're still asking. Does the patient have thyroid? So simplest thing, in fact, this is a favorite investigation I realized of endocrinologist. Endocrinologists will often suspect and will send it for an ultrasound in their hospitals to do a muscle test. So what do we see? We see classical enlargement of muscles. They of course can't read it, so they'll send it. But what is of course the thing that we need to know? It is tendon sparing. If I ask the residents here, what is the size of roughly the size of the belly of the muscle?
Can anyone answer? Shashmita.
Sir, I can't see
Shweta?
anyone actually.
Susmita, are you there?
Yes, sir.
Yes, please speak.
Around 3 mm.
Yes, correct. So actually it's around 3.4 to 4, 3.5 to 4 mm, Susmita. That's very good. So are we going to be sitting and measuring? No. But what we do need to know is when these measurements are done, whether it's USG, CT, they have to be done at the belly, which is usually around the equator. You don't need to do that, but if you're sending it, do write a note to your radiologist with a request saying that I'm suspecting a thyroid ophthalmopathy and I would like measurements of the muscles. Okay, because some often people, if you're not confident of reading, it's just written, this muscle is looking normal. But then to me, when I compare all the 4 muscles, one does look bulkier than the other and measurements come into play. So, of course, 3.5 to 4 mm is the normal belly of the muscles. It is tendon sparing. So, to differentiate, how do you know? So, here is a patient presenting with bilateral acute red eye, proptosis, dilated corkscrew vessels. Now, some of us know this is the triad. What is a triad? Dilated corkscrew vessels, proptosis, acute red eye, sometimes raised IOP, can be acute thyroid eye disease. But when you looked at it on a USG, it was found to have a large superior ophthalmic vein, suggestive of a CCF. Similarly, in this lady, she said that there was a sudden onset proptosis, but it's a quiet eye, right? So I said that, and she had a restriction of movements. And you can see the eyeball this is straight and this is pulled down a little bit. So before, something was not looking correct for me in this. So we did a ultrasound and a classical scolex was seen. So she had myocystis. Okay. Now coming to CT scan and MRI. One, would you consider doing CT scan or MRI? If I know a patient has come to me for thyroid eye disease and has these, either uni or bilateral proptosis, which is recent onset, history of diplopia, there is a subtle squint or early squint, or it's picking up, diplopia with a very subtle squint. Patient's color vision is little distorted, suggestive of possible optic nerve decompression. If I'm planning an orbital decompression, then some of these patients, as you can see, I will go ahead and do a CT scan immediately or an MRI. I also do a CT scan MRI when a patient comes in moderate to severe disease, which we'll come to later, where I want to plan treatment. I never plan treatment without doing a CT scan and MRI because even after we'll go through the classifications of how you document, and we have a very thorough documentation in place and follow up, which the residents also know. Then that documentation also involves a CT MRI, especially if I'm going to be starting treatment. Not necessary for mild cases, but definitely for moderate to severe. So, what do you see in a CT scan, and why is CT scan better or MRI, which I'll come to? So, type of disease, fat disease. What is fat disease? Fat disease is when there is a enlargement due to deposit of the GAGs or glycosaminoglycans glycans more in the fat, where the muscles are spared. So, you tend to have slightly more quiet eyes. As you can see here, the muscles look okay. There is proptosis, there is stretching, but this is just fat as opposed to something like this, which is predominantly muscle. While this goes a little bit into more hardcore oculoplasty, the reason why I'm saying is this: not every thyroid eye disease patient will present with a red eye. We now have white eye thyroid eye disease where the patient presents with proptosis and not necessarily a redness. And in those cases, you may have that these patients tend to have fat disease, and sometimes it's mixed where you have fat and muscle. So, if in these cases where you have all these and there is a crowding at the orbital apex, you want to get a visual field done. Second is, along with the fat, the muscles, don't forget to evaluate the tear glands. Now, this patient was a young patient in the 30s with no other sign except proptosis. But can you see such large bilateral, so much so that I was like, this is possibly an autoimmune disease and not thyroid. And we did do tests for both, and it consistently came to a thyroid eye disease. So also remember to review your lacrimal gland. Then we come to MRI. Now the main thing with MRI and thyroid is that MRI picks up any active element because it contains, especially the T2, it manages to see the water content in the muscles. Now while that is going into too much detail, it is not a mandate to do an MRI in all thyroid eye disease. So when would you avoid it? Suppose the patient has been given a radioactive iodine, or the endocrinologists have sent it to you for a evaluation prior to planning. It's already proven thyroid, and maybe there's subtle signs of thyroid eye disease, and says, okay, I want to do radioactive iodine. Can you rule out if this patient is active? Because you don't want to do it in active thyroid eye disease that can worsen with radioactive iodine, the thyroid. So in those cases, I would say, okay, they're planning for a radioactive iodine, maybe I'll just avoid a CT scan. So the dosage of exposure is very small. In those patients, you can avoid. CT scan also, if I see that this patient, down the line, maybe there is, if it's an inactive, I would do a CT because I need to see bone for a decompression. And sometimes if I know very sure it is a thyroid eye disease, it's a no-brainer, then I do not necessarily have to do an MRI. I just stick to a CT scan. Similar features are seen, okay? And of course, that it helps a little bit more also with optic nerve. So we come now to the second point. So before that, is there anything that I can help answering any questions? Okay, so I'll go on. So let's do the ABC. So we've said, okay, is it thyroid disease? Am I suspicious? So how active is the eye disease? That is the phase. How bad is it? Which is the severity. And C is the classifications that are there. So this is Rundle's curve. What is Rundle's curve? So Rundle's curve is a curve which shows a bell-shaped rise and then a plateau. I think most of the residents now know about this. So what it basically Rundle did is that he based, they consider that thyroid is a type of autoimmune component. So they said that how much is the presence of the inflammation? All autoimmune diseases have a finite physiological response. So there's an active and then there is a a quiet phase or inactive. So in this, what they're saying is that the active phase, that is the phase of inflammation, is the time when changes happen in the eye. Whereas the inactive is when the changes have already happened and you've got all kind of, sort of permanent changes. So this active phase is the phase where we want to treat it and basically bring this level down. Now, when Randall plotted this, he plotted it and saw the response to immunosuppression. Okay, so that was the one thing that maybe when we're coming and treating in a little more detailed treatments we end up doing, that is something we need to keep in mind. But the basic bottom line is this is something we want to treat. Nowadays, there people say that Randall's curve is not really, essential for treatment, but just to encourage residents to sort of make a plan on paper, we draw the Randall's curve and say, think where you want to plot it. Okay. And another thing we make them do, and both of these are there, especially the next point that we'll be coming to. And once you treat it, this is the phase where we are only going to do surgery. So, what do we see in the active phase? We see that the patient's eyes are red, there is edema, there's congestion, there's proptosis, there's strabismus, there is involvement sometimes of the optic nerve, and this usually lasts for 6 to 18 months. But 6 to 18 months from when? Now we go back to our history. When we ask the patient, when do you think you or some relative noticed it? So we in our paper have a chronological history taking where we write according to the year and month. So suppose someone tells me I had got the bulging a year ago around November. So we say, okay, 2023 November is when they first noticed a bulge. So it gives us that from that point it's 6 to 18 months, and we know that that is the active phase. When in inactive, it's usually there'll be a squint, it will be white, and patient is sometimes had already suppressed the eye and don't even have diplopia. So coming to the second, so you have to assess the severity, but you want to know how bad it is now, the severity. So Moritz and Courney basically came up with this clinical activity score to grade the inflammatory phase. Now we know it has two parts. Now they're saying let's grade it. So it is again based on immunosuppression. So what is this? So based on the signs of inflammation, dolor, rubor, tumor, functional deficit, they made these 10 points for each, for pain, redness, swelling, impaired function. So we basically have, and there's a modified version of this, which I've not put up right now, just to give, because I feel that's a little bit too detailed. But this is a printout we have on our board in the clinic. And sometimes it's not like you have to mug it up. You just go and say, okay, if you're taking a clinical activity score, go through it and write it down, clinical activity score this when you're examining, besides the classification. This at least tells you what severity the patient has. Okay. Now coming to the classification. So why were all these classifications made? They were made to know the phase and the severity of whether it's activity and severity. So Rootman and Dolman came out with from this group of international thyroid eye disease, and they basically, the 4 disease, or it's called the visa classification. This is basically a very good paper. It is a little extensive, but it's good. So this is the sheets that we have. Do I use it? I actually have made a modification of visa classification, a little bit of Yugogo, something which is simple in the OPD for me and the students to do and make it quick. But if you're publishing a paper, then this is definitely something that you would like to consider. So this is something that you can all read up, where they have given basically, based on vision, inflammation, strabismus, and there are points and you can just circle or tick it off. Of course, this is an exam favorite, but I feel that seeing some of the last few years MS, DNB papers, we have lesser of Werner's Nussbaum's classification and more of the more detailed classification. At least that's what my students and we've seen a trend of. So Werner's Nussbaum's classification again is based on the acronym of NOSPECS, and it's basically divided into infiltrated and non-infiltrative, and they overlap. And it's similar to basically again going into active and inactive phase, if you notice. So this is good to know for theory. It's something that you need to read up, but it's not something necessarily we use in our day-to-day practice. There is one more classification, Hugo, which I'll come to, but what are the other risk factors that you want to know? That smoking basically is very severe and can worsen it is twice or even 5 to 7 times in patients who smoke. Patients with diabetes also have more severe disease, and older patients also tend to have more refractory conditions. we have a 48% association with myasthenia gravis. So a patient who is on treatment or not treatment, suddenly with a lid retraction starts developing a ptosis, you want to consider that the patient may have myasthenia and do an ACH receptor antibodies. Now, Dr. Ajit was talking about this. So this is actually written, is in the DOS journal, which I've also shared with my residents because I really like this because it's so nicely written into eyelid, facial, EOMs, pupillary, and others. So the others are mainly conjunctival. So this is, I won't say they expect you to rat out all 25 signs, but they basically do want you to tell at least the common ones. So, what are the summons of the common ones? The most common, of course, presentation is Dalrymple, please, lid retraction. Any others which some of you know, which are written here, which you see? Von Graffes, again, very common, okay, which we see. The other ones, which some of you know, Cockers, okay, because when you are asking the patient to look and you say stare at your finger, okay, you automatically see this sign. Then also the Stelvax is something you can see, but it's a little slow. This is something that's available on the net. We were trying to, one of my residents put it all together, and then we said, no, you know what, let's just take this and put it up. So these are definitely signs that you know. And basically, the way I tell them to remember is outside to inside. So you go from face, lid, EOMs, pupil, conjunctiva. These are the signs that you basically want to go outside to inside. So it's easier to remember. No, you have to know all, but remember at least 2, 3 of the main ones which you're seeing in the clinics. Okay. Coming to management, there is also a UGOGO classification, which is by the European group. Again, it's quite extensive. It's not something you want to use, but you may need to mention it. So finally, coming to management, management will be a little bit interactive based on how we see the cases, observations, supportive measures, medical, surgical management, and radiation. So what do we do in observation? So this is a very nice, simple article, which is quite easy for even residents to read. It basically talks about active and inactive management. So supportive, very simply put, is topical lubricants and gels. Medical management is oral steroids, intravenous steroids, immunosuppressives, and of course monoclonal antibodies. Surgical management, which is decompression and radiation. So this was an article that was written by me and Dr. Akshay Nair, where it is there. I'm happy to share it. It's basically targeted towards, it was for residents. It's called an algorithmic approach to thyroid eye disease. And it literally breaks it down in simple terms, the way we have asked the questions and how you should be treating it with simple signs. And it's a very quick read so that you can also format answers from it. So mild disease is basically lid retraction, soft tissue involvement, maybe a little bit of symmetrical or asymmetrical proptosis, but no diplopia. And of course, there is usually no exposure. The first and foremost is to work with your endocrinologist and get them to be normal. Okay. And then you want to give supportive treatment. If the patient's thyroid levels are fluctuating, everything is going to be a struggle for you. But you also have to tell the patient that once this becomes normal, thyroid eye disease takes another track of its own where it behaves like a disease and it will follow its own path of physiological timing. And that you have to really explain and counsel. Moderate to severe is something we must treat. Usually people wait for moderate till go to severe, but we no longer do that. So I am all for treating moderate diseases, whether they are symmetrical or asymmetrical, but it saves a lot of trouble later. So let's come to this. So here is a lady in her early 40s. What would you notice in this?
Yes.
She said that one of her eyes looking bigger.
Yeah, maybe Geetanjali.
It's
We
just
need
a
to
very
ask them by
casual,
name.
nothing
Yeah,
too
we need
scary,
to.
very simple ones.
Yeah.
You can just try, like I tell my residents.
Dr. Sania.
Ma'am, this left eye bulging and
Okay,
left
subtle
eyelid
proptosis.
retraction. Yes, left eyelid retraction and
down gaze, lid lag.
lid lag is there.
So this lid lag is, you know what lid lag is, right? It's defined as a delay in the eyelid movement when you're looking down. So what does lid lag signify? So it's basically, I tell them that lag of thalamus is inability to close the eyelids, but this is when there is a lag. So this means that my LPS is getting involved, right? It's active, it's inflamed, and maybe becoming a little fibrotic. So this, she did not have any idea about thyroid. So what did we do? We basically followed this rule of 1, 2, 3. Was it not? So asked her to get a thyroid profile done. Simply, she only gave a family history of thyroid eye disease. She turned out to be hyperthyroid. This was very early, mild with very subtle proptosis, lid retraction, and just a subtle. And we did no treatment but observe her. And oh, that photo's not come up. Okay, because I have a photo of her which she came back after 6 weeks, which is what I call after they've just been diagnosed. And without doing anything, her eyelid had come down and her proptosis gone just because she managed. So these are milder cases where you don't need to do anything at all. Okay. Then this is again recently diagnosed. What do we see? Bilateral. She complained of bilateral upper lid fullness and proptosis.
Let someone answer that. Dr.
This,
Rahul?
this, sir, I've already said. I'll give another one. So she was recently diagnosed, but it was all over the place. So I said, nothing to be done. It's symmetrical. Let's leave it alone. So we just left it alone. We counseled it, gave her just tear lubricant eye drops. Now let's go for this.
Dr.
So this
Rahul?
is a 28-year-old girl who came.
Nahid, Dr. Nahid?
Yes, sir.
Yeah, bolo.
Just whatever you feel. It's just like, seeing a clinic. I mean, we don't have to be absolutely correct.
Ma'am,
And you
left
already
eye
know
have-
that.
Left eye have the lid retraction, and
Yes.
there is scleral also in
Excellent.
the lower eyelid.
And thoda proptosis also.
Proptosis is there.
Right. So she basically again had come with this, got an endocrinology reference along with thyroid levels. Turned out she has thyroid eye disease and she had hyperthyroidism. Did a medical management, which was just with the endocrinologist. And look at her now. Can you see? I've not done actually any treatment. We just controlled her levels and she followed up. I told her you have to follow up every 3 to 4 months. If you see anything becoming bigger, smaller, anything, then you tell me. Okay. Now, again, recent onset thyroid eye disease, upper lower lid retraction, a little bit of lateral flare. Okay. But she had to be given because they were planning RAI because her thyroid levels were so high that she was unable to be in control and she was already taking treatment for over a year. And in her old photographs, this was the same thing. So I gave now, so this is mild to moderate, where the patient had very subtle proptosis, eyelid signs, but they were trying to plan for RAI. I could not give her, we could not plan the RAI until we controlled a little bit and caused an immunosuppression. And this is her after giving her oral steroids at 1 milligram kilogram body weight. However, having said that, I don't give, if the patient is 70 kilos, I don't go up to 70 kilos. My upper limit is always 60 kilos, which is in divided doses of 30-30. Okay. So again, a hyperthyroid, known hypothyroid. This is to show you hypothyroid presents, lid retraction, again having lid lag, well-controlled thyroid pack, but early active thyroid eye disease. So I asked her to do thyroid, a CT scan. This is just to show that her left eye is actually showing an enlargement. Okay. So again, oral steroids, and she resolved very well, including the proptosis. So mild to moderate, you could consider giving oral steroids. The new drug which has come in is mycophenolate, which basically mycophenolate mofetil, which is really good. I've not gone into details about that, but that is something that you may need to mention in newer treatments. Now coming to active thyroid eye disease, which is bilateral. So here is a lady in her 40s who complained, was known to have, and she was like this, and she was following up with me. And then suddenly she started worsening. Till then, I was not giving her any treatment except teoleucadins. So there was no change in her thyroid levels, but she developed active thyroid disease with proptosis, bilateral lid flare, lower eyelid retraction, congestion, blurring of vision. So in this case, okay, we had to give her intravenous steroids. Okay. Oral steroids we had tried earlier, which still post that she developed it, and we gave her intravenous steroids in the form of pulse therapy. Okay, I'm going to come to the entire course of pulse therapy a little later, but these are just some patients who come. Again, bilateral thyroid eye disease. Okay, moderate to severe. Thyroid levels controlled but worsening. CT scan shows 3 muscles on both sides involved. Asymmetry. This is another lady who came with acute thyroid eye disease with drop of vision. And in both these patients, we have given intravenous thyroid. So my thing is similar to what I learned in my fellowship with a little bit of modification. I give a loading dose of 4 to 6 grams. Usually we admit them for 3 days and give either 500 milligrams TID for 3 days, okay, with a pulse every 2 to 4 weeks, usually at 3 to 4 weeks, where we give 500 to 1 hand. The total cumulative dose in the entire lifetime, you shouldn't try and cross 8. Having said that, this loading dose now, I don't necessarily always give it to patients and admit them. Sometimes I give it unless their vision is very bad. We usually give them, at the first dose and then call them either 2 to 3 weeks to later to give it. However, the UGOGO study says 6 weeks and 6 weeks, which can be given in very acute severe cases, but I'm not a big fan of that only because sometimes I find that the patients who are moderate sometimes end up having a steroid rebound. At the 4th pulse, we usually add an immunosuppressive. Okay. And that is the patient after 4 cycles of intravenous. Similarly, this is just to show younger patients also come with similar, and you have to give them intravenous. So these were 4 to 6 pulses. So it is not necessary the patient may need 6 pulses. Usually 4 pulses given at every 3 to 4 weeks causes an immunosuppression, which can be combined with oral steroids in intervals between the cases, or you may not give them. Now, this is the same lady who came and we gave intravenous, but after that, she developed after about the first dose, she again developed her vision went down. So here is a case which is severe thyroid eye disease with optic nerve compression or dysthyroid optic neuropathy or DON. In this case, we had to do an emergency thyroid eye decompression of the medial wall, which we did with an endoscopic approach because it was unable for me to go through a classic traditional approach. So an endoscopic approach was done. So that was how it was, a CT scan. So loading dose, this is how we give it. There are, again, it's there in the articles which I can share with you. So pulse treatment is required for moderate to severe and in cases with DON. Okay. Now, we talked about active disease, but what about one feature which comes recurrently? I just wanted to share with this because this is something they ask is this very horrible thing, which is actually, sorry, it's not here. One sec. I wanted to show, which is basically, okay, I'll just go ahead and show it to you, which is lateral flare. So what is lateral flare? Lateral flare is when the lateral part, 1/3 of the eyelid appears like a winged appearance because there is more fibrosis and inflammation in the lateral part of the LPS, which has been found on many studies that this part tends to be inflamed and more retracted. So in these cases, even in active disease, there are some of the treatments that you do. One is giving Botox into the lateral part, hitting directly Mueller's and LPS so as to induce ptosis. You can give anywhere between 2.5 units, international units of 5 units, and it can also be given in inactive. But in active, because their appearance becomes so bad, it's a condition you want to give. The reason I put this is because there was a short note once in management of eyelid retraction in one of the DNB papers. So that is why we've put it. Second is similar. This is again, she had bilateral upper eyelid retraction with lateral flare, and this is post the injection. Okay. Now, what we've also can give, which is really good and has absolutely amazing results, is giving transconjunctival triamcinolone injection anywhere between a dose of 10 milligrams to 15 to 20 milligrams, which is given in the tarsal. You have to evert it. It's not in the lacrimal gland, sorry. And you have to give it into the Mueller's muscle, and it causes a very good thing and is a little more permanent than Botox, which lasts only for 3 to 4 months. Now coming to the management of teprotumumab. Now teprotumumab is a monoclonal antibody which has been described and is considered the wonder drug abroad, which basically why? Because in its active phase or even in early stages, it not only reduces the eyelid retraction, but it has caused a significant reduction in proptosis of 2 to 3 millimeters, which no other drug has been able to do. However, of course, here we still don't get it. It's not FDA approved here. but it's off-label market is available, because I have had patients who've come to me saying that I can get it. Can you give this to me? But we tend not to do it, especially if it's because of our hospital protocols. But I know that it can be done. Coming to inactive thyroid eye disease. So in a patient like this, which had bilateral lid retraction, she's happy. She didn't want anything. I wanted to consider doing something for her cosmetically, and but she didn't have anything on her visual fields, nothing. And she basically did not want any further treatment. So we left it alone. So then post this, what about patients who want something? So there is an algorithm that you have to follow. Decompression surgery, followed by even lower eyelid retraction to increase it, squint, okay, and then of course eyelid surgery. Okay. Why we don't do squint before this is because in the squint also there can be a little bit of proptosis which occurs, which you have to take it into account. And that might be too detailed. So I just want to show this. So these are the two main peoples whose decompression rules we follow. Okay. And the types of decompression are lateral wall, medial wall, floor, and fat. And we do a combination of both. Now, this you don't need to do detailed. You just need to know that decompression is something that we follow one of the treatments. So in this case, this lady had inactive thyroid eye disease with unilateral proptosis, no lid retraction, but was about to get engaged and wanted. So what can we give her? So we offered her only what we call as fat decompression and match the eyes through an eyelid crease. This is a very severe bilateral thyroid eye disease in which this is after the first surgery. We did a bilateral 3-wall, medial, lateral, floor and fat. So medial wall decompression is something that is a little tricky, where you actually decompress and remove the entire medial wall, and that can be done endoscopically or traditionally through a transcaruncular hidden incision. Okay. Do I have time to just play one short clipping? These are towards the end, the slides. So we go through a transcaruncular approach. And once you've dissected subconjunctival tissue also, you have to go straight behind the lacrimal sac. So that's feeling for the posterior lacrimal crest. So this is just to give you an idea of how the surgery is done. It's a very, very short clip just to give you that these are the approaches we use, and they give very gratifying results, especially in patients with bilateral thyroid eye disease. A lot of time you can either do it endoscopically or combine it with, if you are comfortable doing endoscopically, you can either do it with your ENT surgeons. So that's removing the wall. Then you disrupt the fat so as to have a decompressive effect. And that's how you're using a DCR punch. Then is the lateral wall, which I'll skip. So here is a patient of severe thyroid eye disease is inactive, in which all three was done. And that is how radical the patient's appearance changes. This is a floor, lateral wall, medial wall with fat. And it's life-changing for them. This was during. So, sorry, this is a repeat. So upper eyelid retraction can be done with only upper eyelid surgery by recession. So this is all done when the patient is primarily inactive. If you try to do this in active phase, you have to warn the patient that there is a possibility of recurrence. So these are some of the surgeries that we do. Now here is a patient, and I'm coming towards the end of my presentation. So this is to show you. So it is a known case of thyroid eye disease, but like we discussed in history. So now he has an asymmetrical inactive thyroid eye disease with proptosis, did not want any treatment. And let's see what happens in the video. Can you see? He's developed a ptosis. So on doing ACH receptor antibodies, he basically came positive and had to be treated for myasthenia. So large 40 to 50% of these patients do end up sometimes having myasthenia. But then when their eyelids are retracted, they end up becoming a little ptotic. Okay. Similarly, this patient also developed a ptosis and he did not have myasthenia, but we corrected it. So he was negative. I want to end by showing this paper which I received an award for, and only not for so much for the award, but it was something that we did differently, and we presented it in the ITES meeting. Was that we did basically a QOL, quality of life, which was never done in Indian patients, but it was not done in Indian patients. With we added two things. One is to assess just the quality of life, evaluate the correlation, and we added an Indian component where we said traveling by public transport such as buses, train, and second, the effect of impact of arranged marriages and how it impacted the Indian population and the appearance. And we basically got this results, which was that basically it didn't really impact public transport, but 95% were affected by change in their appearance. And 28% had an emotional thing of feeling that they were a burden on their family. And 12% felt that they needed to hide it before the marriage. So this gave us some insight about how important counseling is. This was the article I was talking about. So in a nutshell, you need to do a good history and evaluation. While you may need to know all the eyelid signs, once you start practicing, you don't really need to know them by heart. So you need a good ophthalmic evaluation. Eyelid signs can be reversed in early acute stage. So it is not only the diplopia and squint which needs to be taken care of. Subtle eyelid signs, please evaluate, do history, do imaging, do blood investigations. And you have modalities now which are non-invasive OPD procedures. Please involve your endocrinologist and be in communication with them. It is very important because your thyroid patient often is like a retina patient who's with you for a while. And surgical managements are almost always customized individually, and there is no one technique fits all. Thank you so much. Sir, I can't. You're muted. Dr. Ajit, you're muted.
It's an excellent presentation, ma'am. Resident, anything you want to ask? Students?
Very nice presentation.
Any doubts? If you have any doubts.
I will ask one doubt.
Yes.
Sir.
You said the pulse therapy along with oral steroids. Why should we do that?
So, in some patients who are very severe, pulse therapy is not enough to keep the steroid or the cortisol level maintained to get the immunosuppression. So, you need to add, based on their weight between the pulses, you can add oral steroids. And that helps maintain. Otherwise, as soon as you give the intravenous steroid pulse, within a week, they tend to come back to you. Having said that, sir, MMF has been a little bit of a game changer. We also now are giving our patients MMF, and sometimes we may be continuing MMF and may not even end up going to pulse. Pulse specifically, we give in patients who are starting to develop diplopia, have significant bilateral asymmetrical muscle enlargement, and especially if we feel there is a crowding of the nerve, though the nerve on visual fields and other examinations may be normal, because those patients tend to respond very well, and often we don't even give loading doses in them. We just do a 3 to 4 weekly cycle and introduce immunosuppressives in the 4th cycle.
Dr. Savri,
I have one doubt.
Yes.
Dr. Savri, what is your experience with Hashimoto's thyroiditis?
So Hashimoto's basically doesn't present with such classical signs of thyroid eye disease, honestly. So when initially the endocrine used to send it to sometimes, and it was a bit of a learning for me also with my endocrine team at Hinduja, that they will not have classical signs such as proptosis and eyelid retraction. So from our point of view, there is not much that we need to do. We
can present with proptosis, and then it becomes really difficult to treat them sometimes. Like sometimes it comes proptosis, and then again, because it
is an autoimmune, but primary mode of treatment, we can treat them. But like I tell those patients, primary mode of treatment for them is with the endocrinologist there. Yeah. So what they do is sometimes they send me for a baseline investigation, And then we just sort of not even do a 6 to 8 week follow-up. Sometimes we do a 3-month follow-up just to see that there is no worsening.
Dr. Savri, do you prefer giving orbital radiotherapy in active TED cases?
Yeah, so actually
It's
that
first-line
slide,
therapy.
that slide was after my thank you. I forgot to put it because for radiation it's a little more advanced, but it's something that, so we have very specific indications. I think Dr. Suryasnath Rath from LVP Bhubaneswar has a series which is printed, and we had discussed this. My indications are very clear, though I have a great radiation team in Hinduja. We've done it for 2 patients. One, my indications are when they are not responding to any other treatment in the form of usually intravenous steroids, or they have had very bad reactions to intravenous steroids. They are refractory. One patient developed a steroid psychosis, which is why we had to give them. So, not able to take steroids, not responding to any other immunosuppression. We have then given them radioactive radiation. Second is when also after this rituximab is something we've tried. If the patient is given a trial dose of rituximab and there is no reaction, then rituximab is something that, is something that we do try, which we've had patients respond in severe thyroid eye disease. So before radiation, we even try that. The third one, which again, I think there was a paper from SN and this, which was about tocilizumab, where it didn't work like teprotumab with proptosis, but there was seen that it caused some amount of improvement. My radiation is given for very severe patients when they are not responding to any of these diseases, because our response is not like a Caucasian response. So we don't have to give it. And we've literally had 2 cases, one refractory to any other treatment, and second who developed steroid psychosis after 2 pulses. So we debated about giving rituximab, this, that, and then we decided to just go ahead with low dose radiation because we just didn't want to take a chance with anything else. And it was quite severe, and we needed to treat it. So that it is not something that we go immediately, but yes, we do have that, we can offer it. So these are my indications.
Management and monitoring.
Yes,
Even
Sahib.
even at AIMS, we do give RTs, but again, as Dr. Savri said, that those all refractory cases, those who are not responding very well to steroids, as the RT becomes the last means of treatment for us. We generally switch them to rituximab firstly, and then most of the patients under endocrine, they receive rituximab on the daycare, and on continuation for maintenance therapy, we switch them. Right. Again, recently, I remember we had a patient who was not able to take steroids. Even after decompression, there was on and off episodes of again decrease in vision. There was some indications for the patient again going in dawn. This was another patient where we had planned an RT with the radiotherapy department at AIMS.
Yeah, but maybe after surgery, especially if you've done decompression, I wouldn't jump into giving radiation unless, like you said, it's very severe.
But again, the patient was going in on and off episodes of.
Yeah. So though this might be a little advanced for the residents, almost, and then there's enough literature. I have definitely found, I was not doing this in the first 5 years of my practice, but in the last 10, 12 years, we do tend to give, even if a patient comes to me in relatively inactive disease, I do tend to give the patient at least 1 dose of intravenous steroids prior to the surgery, because I feel that the reactivation post-orbital decompression definitely goes down. I have only had 2 cases of reactivation, but I have struggled with those post-orbital decompression. One came, I know them by heart, one came at 9 months and one came at the month, and it was very unnerving to have to go back and do the whole thing again.
Very true. We become clueless about how to go ahead after that.
Yes, because there is not too much medical literature on reactivation and its management. Do any of the residents want to ask just simple questions? I mean, like I tell our students, you might as well ask the simple ones, because I think exams, they don't go into so much detail. They ask you simple things like,
Dr. Savri, this is a question for the residents, and you will answer that. Why is the incidence more in the females than in males? I think it is probably 4:1. Females are more affected by thyroid eye disease. And what is the reason behind that?
You want me to answer or the residents?
No, you can. The residents can answer. If they do not answer, you
No, I
can.
got confused. I couldn't. That is so. That is like a lot of the race predispositions. Like Indians have a lesser phenotype. Basically, I mean lesser predisposition as a race. So women are basically known when studies was done as have a further predisposition to get thyroid eye disease because of the just because the way they are physiologically they tend to have more thyroid eye disease manifestations.
The severity is more in case of men.
It's 7-1, if I'm not mistaken, actually, more than 4-1.
Yes, 7:1.
Yeah. But I don't see that trend. I actually see that because they end up being non-smokers, especially in our country, I see that it's almost balanced out because the men who are smokers who always end up coming with it is like it's an uphill task. They will not respond. They'll respond, they'll worsen until they try. So one patient of mine actually gave about a couple of years ago was my learning lesson, because he said, I am unable to quit smoking, so you need to figure out how to help this for me. And I then reached out to my chest physician because since I'm in a multi-speciality, and he said, yes, we have a program to quit smoking. And then I was like, oh, okay, I didn't know that. And I never thought that that would be something that I would be using. So if a patient reaches out and cries for help, that's something we say, okay, that you'll have to visit the chest physician. You will have to do certain tests, which may be an additional cost, but they will guide you on how to do it. Instead of,
Even
because
for the
otherwise it's very easy to just say, start chewing nicotine and all. It's not something that's done. So now we luckily have.
Question for resident: which extraocular muscle is more commonly involved in thyroid eye disease?
Can
Which
ask my name.
extraocular muscle?
Can ask my name.
Yeah, that's a great question.
Yes,
Inferior rectus.
The inferior orbital. Inferior rectus. Inferior rectus
Yes,
is most
inferior
commonly
rectus.
involved.
Then
Medial rectus, ma'am.
Yes.
medial
then
rectus.
Followed by medial rectus, ma'am.
Mnemonic goes, I am slow, I guess.
I am
Yes,
slow.
I
Yeah,
am slow.
so that is
I
a
am
mnemonic. Another point is I want to highlight is the role of exophthalmometer, because thyroid disease is a chronic disease. So the resident too should know like how to use an exophthalmometer. Yeah. Mostly we have that readings, which is one is the base reading, which has to be constant for every visit, because we have to take seriously and find out like what is the progression or regression of the proptosis or exophthalmos, because we are dealing with the endocrine disorder, which is systemic. Along with it, it is a ophthalmic manifestation also. So they have to know like the different type of methods how to diagnose the proptosis, like clinically.
So, Dr.
So,
Meher,
like-
that's a very, very valid point. I just,
Yeah.
I've assumed all my residents do it. So I actually missed out. I could have put the slide of demonstration, or
Yes,
we have a
yes,
little video, but
Yeah.
all our residents learn. That's absolutely right. We do not, in fact, we even do Shermers in
Yes.
all our patients
Dry
in the
eye
first
workup
visit.
is to be
Yes.
done.
So all measurements, Shermers, Herters, even if it's a follow-up, I think my
Absolutely.
patients try not to take the thyroid file, because even if it's a follow-up, everything needs to be measured and written. So
Yes.
yeah, so definitely that's very, very important. And exophthalmometry itself is a full mark question which comes. So yeah, you have clinical, radiological, comparative. So that is
So any resident who can name some of the exophthalmometer, it may be from the simple to the complex ones.
yeah, that's a great question.
Elisa, are you there?
A simple one, simplest one. You have nothing with you, still you have something. You can. Your voice is muffled.
Dr. Elisa, your voice is not coming properly.
It's breaking. No, I could not get it.
Rupali, Dr. Rupali? Dr. Rupali?
Yes, sir.
Can you answer Dr. Meher's question?
The types of exophthalmometer, from simple to the complex. I mean to say from simple to advanced, like unilateral or bilateral. I'm making more specific. From your bedside to the newer instruments. The simplest is the
Sir, Hartel's exact thermometer.
yeah, that is in the higher range. If you don't have Hertels, because not always you have that privilege of getting a Hertels. What else? A simple thing is a scale, okay, ruler scale, a plastic transparent ruler scale. Of course, there is
Yes,
a
sir.
very rough estimation, but still you can have it. Put it in the lateral orbital rim and just find out the corneal apex and just see the reading from the side, of course, not from the front, from the side. That is one thing. Another
Yes,
thing
sir.
is leads you have, of course. The noggle, of course, there is a fracture or anything in the orbital rims, lateral. Then that can be used in the forehead, like in the frontal area, and that you can see. And the Hertels, of course, everybody knows. So that can be used for the exophthalmometer, which gives the exact serial progression of your disease process, which has to be documented because these are all documentation which has to be done for this type of.
Yes, sir.
And second part is about the treatment part, the chronic phase and the active phase. There are two divisions. We mostly confuse because patient presents at varied times. They doesn't present at the early stage or they come at a stage where they've already undergone a lot of treatments and there is refractory condition of the eye. So they have presented to you. So certain investigations like MRI can say you or differentiate whether it's an active or inactive phase. So active phase, always the medications works very beautifully according to the gradation what Dr. Savri has told, starting from the steroids till the immunomodulators and suppressants. And then comes the inactive stage. So that is mostly the rehabilitation phase mostly. So we should not go for a active treatment in those cases because it will not work if at all you do it. So you have to try to differentiate between the two and try to start it with the appropriate management for the patient so that you are not delaying the treatment part.
One question for Dr. Savri. Do you prefer giving a selenium supplementation?
Yes, I do give selenium in most of my patients. So either 100 or 200 micrograms, we do give it, especially in the patients who come with early active and, to moderate diseases. I do encourage giving because there is enough evidence to show that selenium does have decrease the type of, just sort of helps keep the patient suppressed a little bit and helps for orbital, like worsening of the thyroid eye disease.
For how long you give?
So initially, if the patient has come to me for the first time and is not started by it, then I give it at least for the first 3 months to 6 months while the patient is in the active phase. Now, what I've seen is that I attended the Indian Thyroid Association conference twice. So just once as a speaker and once because I wanted to learn really from their point of view. And they all are pretty aware of this. So most of them started.
Okay.
So I do give. You can give 100 micrograms or 200 micrograms, depending. So,
even in our setup, the endocrinologists, most of the times they started. The endocrinologists who rather start than the patients follow up rather with us.
Yeah. And actually, instead of for pharmacy, it's all available on Amazon. So like, these all these companies which are good, they only have some of the not the non-allopathic, they only have a lot of these supplements which are good.
Also, for residents, while in exam time, we also commonly tend to ask this question: the most common cause of proptosis unilateral in adults, and the most common cause of bilateral proptosis in adults. So, if any resident can answer that.
Thyroid.
Yeah, so for both of them, it's thyroid.
Thyroid,
unilateral or bilateral. So you have a proptosis.
Yeah.
First of thyroid eye disease.
But the only thing is, Sahil, I would say is that the triad that we spoke about, proptosis with redness with this for bilateral, thyroid eye disease, and the second one also would also, you have to also keep a differential. Yeah.
You have to, obviously.
Yeah. And so
And any nomograms for the orbital wall decompression with severity of thyroid eye disease.
So if the patient presents with optic nerve decompression, optic nerve.
No.
Sorry.
The orbital wall decompression, 1 wall, 2 walls, 3 walls.
Yeah. Oh, okay. Okay. So I put that up, but I thought maybe it's too advanced. So if you need about 2 millimeters to 3 millimeters, you can only consider fat decompression. Sometimes you can even achieve 4 millimeters if the muscles are not enlarged and it's only fat. If it's 2 to 4, it is fat plus 1 wall. That wall depends on the way the eye is placed. So usually we try to either do lateral or medial. Medial, then you have to also be sure that you don't remove the entire medial so that there is not an interning or a pseudoesotropia. If you want 4 to 6, then it's 2 walls plus fat. 2 walls, you can do a balanced decompression, which is medial plus lateral. And if it's 6 and above, then it is a 3 wall, which is basically lateral wall, medial wall, floor plus fat. In floor, we have to be very careful of the infraorbital vessels, where patients does develop infraorbital anesthesia. But if you do certain techniques, then the patient does not necessarily have to have it. In this also, the division is whether you do a traditional approach or endoscopic. So endoscopic classically is done for optic dysthyroid optic neuropathy, because you can reach more posterior and open up right at the posterior orbital muscle area where the optic nerve gets space in the apex. But I also combine endoscopic when the muscles are very, very large and I'm doing a 3 wall. Then we do first the medial wall, open it up, and that gives me space to then do lateral wall.
Okay. Right. Maybe we can ask the residents to ask questions.
Yeah. So all the residents are silent. They are all.
Yeah. This is very common topic even for the exam. That is the main problem.
Yeah. Inactive, actually, I tell my residents that even active disease sometimes is kept, but inactive is usually kept. But most of the times, I think from whatever we've seen the trend over the last, even being a DNB teacher, we've seen that they don't really want to know. It's like actually Dr. Ajit said very correctly. They want you to be able to just find the signs like proptosis, eyelid retraction, pseudoproptosis. Why do you think it is thyroid eye disease? What are some of the signs that nobody expects you to know all, but they will ask you common ones, and basically differentials for these. And they just need an overview that medical and surgical management. If it goes up to decompression, then you're definitely done very well.
Super topper.
Yeah. I think the thing that to encourage any of these residents, even if they don't want to ask questions, is that when you get a thyroid eye disease, of course, immediately you may not know a lot of things, but start by simple things like history. So, just to know that, okay, when did the thing start? What is your this? Okay, what is your investigation? We write the date the investigation was done. Once you know that, that itself gives a lot of information.
Residents, why don't you ask questions? Dr. Sania, the silent. Dr. Sania, are you there?
Yes, sir.
Just give some comments and give some questions, ask some questions. And आप लोग वीडियो ऑन करो. All of you, please switch on the videos. We can see you.
So what will be the finding in ultrasound in a case of thyroid ophthalmopathy? If you see the muscles.
Yeah, sir.
Is for
Ma'am is
residents or Sabri?
Residents.
Yeah.
Two simple questions.
Yeah.
Sir, ma'am has already mentioned that in time we'll be seeing the enlargement of the muscle of the belly and with tendon sparing.
Okay. And if it's the tendon which is involved also, along with the belly?
We have to consider another diagnosis and not thyroid.
What diagnosis? That will be a differential diagnosis now. Of thyroid now. Tell me, what will be the another diagnosis?
Another diagnosis.
Yes.
That was actually, I put that up also. I just written it. I didn't say it.
Yeah. So tendon with belly. So what will be the diagnosis? Because these are very common presentations which come to the clinic. And
So Sanya, like I tell, if I don't want, I mean, I don't want to intervene, but I just say don't blank out.
yes.
So if there is a muscle, so you have to just go back to your anatomy. If there is a muscle and it's enlarged and the tendon involved, just in simple terms in ophthalmology, a muscle with inflammation is called as what?
Myositis.
Yes,
myositis.
that's right. So
Okay.
don't blank out. Don't blank out when you're in the exam. Just think, okay, it's involved, so it's inflamed and it's a muscle, so myositis.
Yes. So non-specific orbital inflammatory disease may be one of the condition which has all these subsets: myositis, dacroadenitis, and other things.
Yes, sir.
So always see for differentials whenever you get a disease process. You don't pinpoint to one is fine, but still you have your mind in the differential so that you may not miss out something by the time you're treating something. So that is important.
Yes.
And even like we saw about myocystic sarcosis, but that's a very specific thing. But that can be one of the differentials. Then, of course, there are many others, which you have, which is like lymphoma and all. But that is going into, even if you just say myositis and myocystic sarcosis, that itself is.
Even in
And
the
this thyroid eye disease is due to thyroid or it is due to the thyroid gland? Is it? So we control the thyroid status and everything will be okay. Why we are going for all these steroids and immunomodulators and all these questions, decompression? The simple thing is it's a thyroid eye disease, okay, due to thyroid. So thyroid we are controlling, then it should have been controlled. So exactly what is the mechanism for eye manifestations? Going to basics. Anybody? Susmit,
Sir,
yeah, tell me.
may I?
Yes, Smriti.
Yeah, Smriti. Yes.
Sir, because of the multiplication of the orbital fibers which are present, that leads to compartment compression in orbit.
That is fine. That is
which
fine.
leads
Where
to
did
the
it
ocular
start from?
manifestations like
How from the hormone, the thyroid hormone to the pathology? Means what it will be the pathogenesis? Is it directly due to the thyroid hormones?
no,
Which
so
is
it's
causing?
because of the antibodies to the
It's the immune response. It is the immune response basically of the body which causes all these changes to the fibroblasts, to the adipose tissues, and to the muscles. So that affects into the
Antigen antibody reaction, which destroys our body's T cells and B cells, which causes apoptosis of the cells and inflammation.
So basically, these are the mechanisms where it causes some indirect inflammation to the orbital tissues, and that gives the presentation. So even if you tell the patient that the thyroid has to be controlled, the patient should not take it for granted that once thyroid status is normal, the disease process will wave off. So it will not go. Still, there is a chance that it will stay or it may progress. Any other questions from anybody?
About sign. If you have seen the
Voice.
We speak.
I wanted to just say that I really, really wish that when we were doing our post-graduation, we had these kind of lectures. Yeah, now I feel so much available and it's, I know these residents, I keep saying this like one very old auntie to my residents that I wish we had this and they are tired of me hearing say this that, oh, you all have so much, but I really wish we had because we only started having this in fellowship. We just had physical lectures, but You may not have to know everything about a disease, but you learn so much.
Yeah, but only thing is that they are a little bit hesitant to interact.
Yes.
So that happens even with us. They're sitting in front of me and they.
No, it's okay. See, the thing is, we can ask any silly question. What is there? We will learn. No? At certain times, even the simplest question cannot be answered by everyone.
Correct.
Okay.
So they should be outspoken. And at their stage, certain times the questions which will come are really surprising to even the most experienced. So that's how we can extract a lot of subject.
So these webinars are the platform for that.
Yeah. Not only that, best of the speakers are speaking.
They should open up. They should open up. This is the platform.
They should open. They should actually. They should have a list of questions from start only, and they should fire us rather than we firing them.
Yes.
So I think now it's time to close.
Yeah.
Huh? I think.
Yes.
Yeah. So I think Dr. Patnaik is not there. So let me offer the thanks. So let me thank Dr. Sabri Desai, who has given elaborate discussion.
Very elaborate,
on this,
yes.
elaborate
Complete
discussion on this
analysis
disease.
of thyroid eye disease at its best.
Yeah, now we are all experts in thyroid eye disease. So thank you very much, Dr.
Really.
Desai. Yeah, it's a wonderful discussion. So I thank our moderator today, Dr. Madhusmita, to bring out certain questions from the students, and all the panelists. Definitely, they've done their job by interacting with the students themselves, with the speakers. And thank you, Dr. Adi Babu, bringing a nice topic today. And we look forward for another good topic next time. And all the EIZOC people, Dr. Pranab, Dr. Swaraj, thank you very much for giving us this opportunity for
Dr.
this platform.
Jayanta also you should bet.
And of course, our president-elect is there. Thank you, Dr. Jayanji, sitting for a whole episode. And last but not the least, thanks goes to our entered platform. And Rahul is the representative of that platform. Thank you all.
Thank you.
Good night.
Thank you so much, everyone.
Thank you very much.
It was most welcome, sir, and I really enjoyed it.
Thank you, ma'am.
Thank you so much. Thank you, Dr. Madhusmita. Thank you.
Thank you.
Thank you, Dr. Sharma.
Good night.
Bye.
Night.
Have a nice evening. Bye.
अकेले रह गए एक आप रह गए और एक राहुल जैन रह गया